So the main emphasis about this organism is it's a bug that we think has got a wider geographic distribution than we previously thought. It can mimic a number of conditions. The infection can manifest years after primary infection, especially in the immunocompromised, and diagnosis can be a challenge. So with that slightly kind of cryptic beginning, we'll nip on to the first case. So the first case is a 64-year-old woman with a background history of type 2 diabetes, hypertension, hypercholesterolemia, who'd had a previous hysterectomy and some previous ENT surgery, who was admitted to the Royal London Hospital with features consistent with a cerebrovascular accident. She went through the stroke protocol pathway. Because there was concern of carotid artery dissection, she had a CT aortogram, which confirmed a likely left internal carotid artery dissection. But because the CT aortogram included her chest, it also showed that was her CT of her chest. Now, for those of you who are at the back and can't see particularly well, there are multiple pulmonary nodules that were seen. So this is an incidental kind of finding in this lady presenting with her stroke. And this being the Royal London, she had a stroke pathway. Then they did the CT. Then they did the chest X-ray after the CT, and that's her chest X-ray. I think you can see again she's got multiple opacities within both lung fields, and so she goes on to have a more dedicated CT that again confirms the findings of the original one. Again, just showing, I'm no radiologist, but you can see lots of well circumscribed pulmonary nodules. It's interesting listening to Steve Ellis's talk yesterday. The comparison of the different kind of modalities of imaging, that there's no obvious halo sign around these. They're well circumscribed. The real concern about this was, were these all metastases? So that was the original kind of concern. This is a lady who presented asymptomatically from the chest point of view, multiple nodules. This is probably cancer until proven otherwise. And so she recovers very well from her stroke and moves hospital across from the Royal London to Barts Hospital, just where you've been, where we have our local thoracic unit. And she has one of the nodules excised. And so I'd like to invite Dr. Sekovic, one of the histopathologists from the Royal London, to come and talk us through the histology.
So thanks to Dr. Lambourne and the organisers for inviting me to speak to you. So this is a section of lung tissue. You can see a rim of kind of compressed but normal lung parenchyma around the outside. And most of it's obviously this large necrotic nodule with a fairly kind of sparse rim of lymphoplasmacytic aggregates around the periphery and quite large dense areas of hyalinized pink fibrosis and necrosis. So this is a closer look. You can see a lymphoid aggregate on the edge here. Multinucleate giant cell up towards the top here, and scattered in between these kind of bands of basket weave pink fibrosis are a few epithelioid histiocytes, but quite sort of loosely formed, which is quite typical of the condition we're looking at. So at this point, there are some routine stains that we'd ordered. Did people know what we would get at this point?
It's Royal London, yeah. So the first thing I think of is a fungus that's all over the place. Sorry, it's histoplasma. Yeah, that's my best guess so far.
Okay. In terms of investigating a general kind of granulomatous picture, do you know what stains we'd order at that point? I'm looking at this. So we get a ZN and usually a Grocott to pair it with. I mean, it varies by preference. We might get a PAS as well. Some places would do the PAS preferentially. I think the next slide we've got is a Grocott stain. So, yeah, this is highlighting numerous small yeasts measuring 2 to 5 micrometers in size, kind of teardrop shaped with narrow-based budding. So that's the first case.
Perfect. Thank you very much. So, differentials. I think we've already heard a few differentials, TB being one, fungal infection being another. We've seen fungi on that slide. So, we've already had histoplasma as one particular differential. Any other differentials people want to shout out? Cryptococcus. So on the report, so Candida, so apparently Candida can look a bit like that. There's a report saying Candida krusei possibly could look like that, which is a bit odd. I'll come to that. Yeah, no, exactly. So that's a good point. So what would you like to do next then? What other tests would people like to see? Serology? Urine antigen test? Anything else?
Presumably this was all informative, was it?
No, because it was, oh, well, hang on. I'm not sure about this case. No, it wasn't. It was sent to us. So we had it as well. So exactly. So we got some of it. So routine mycobacterial culture was negative. We did a gene expert as well, which was negative. Routine culture was negative. We did request mycology, but this was slightly after the event. So the tissue had been sitting in the lab. We got the histology report back at about kind of day 7. So we fished out the old sample that had been sitting around. And we did some mycology, and we plated it out. And we saw fungal hyphae. And we grew penicillium, and we identified penicillium by 16S PCR. The slide that you saw before is not penicillium. So our interpretation of this is that the sample was contaminated by penicillium, and the penicillium grew during the time that it was kind of ex vivo sitting in the lab. So when we sent 16S, 18S, of fixed tissue, we got no signal. Serum cryptococcal antigen was negative, HIV and Hep B negative, and just because this person is from Bangladesh and we have a 30% hit rate of strongyloides serology in our local population, their strongyloides serology was negative. We did send their histoplasma serology. We sent it both to the Mycology reference lab in Bristol, and because we were sending antigens, we also sent some histology, some serology to the Mira Vista labs in Indianapolis. And so the UK result came back to say the complement fixation to the mycelia antigen was negative. Complement fixation to the yeast antigen was positive, but at a low titer, so between 1 in 8 and 1 in 16, which was deemed equivocal, and then immunodiffusion was negative. There was a slight discrepancy with the serology from the US lab, which said, again, the mycelial antigen was negative. Complement fixation to the yeast antigen was positive, but no titer was given, and they recorded their immunodiffusion as positive, but again, no titer was given. The antigen in both serum and in urine was negative. So I guess the question is, what's the diagnosis? This is a lady who presents with a stroke, who we find these things completely incidentally. She is completely asymptomatic. So what's the likely diagnosis, other than she's had a stroke? So I think we would class this as histoplasma pulmonary nodules. The next question comes in terms of what do we do? Do we treat? Don't we treat? What I tend to do is I tend to bring these to meetings and ask the audience to see what to do, which I've done for the last 3 years with various fungal cases that we've had at Bath. So let's have a show of hands. So who would treat this lady? Some fairly equivocal hands below the waist. Let's have hands above. So about 30%. Who would not treat? Wow. Fewer to...
Jump in.
Yeah.
Observe, I think.
Yeah, exactly. Watch and see. And who really doesn't know or doesn't really care? One. Well done. Very good. Yes, great.
The stroke, do they think the histoplasma was involved in any way?
No. So we looked, and there was no evidence of disseminated histoplasma. It was all in the chest. So she did have, I haven't shown you all the imaging, but she had imaging from head to toe, and it was just localized pulmonary disease.
Excuse me.
Yeah.
Did she have previous chest?
So it's a really good question. We're back. So the background to this lady is she's a lady from Sylhet in Bangladesh. She's in her 60s. Otherwise fit and well apart from the cardiovascular risk factors you've seen. No recollection of any pulmonary infection before. I tried to look back for plain films during her Max Fax surgery and her hysterectomy, but they were lost and gone to the archive. There was no mention anywhere about previous films that I could find. And the first pulmonary imaging we have was her CT aortogram, so we don't know. What was interesting about this lady is that thinking about exposures, we'll come on to later, but there were no obvious exposures. But what was interesting was she was in Bangladesh at the time of the War of Independence, and does recall during that time spending time going into a man-made underground shelter several times and for often relatively prolonged periods to hide from the various things that were kind of going on during the war. So there's a potential exposure. She would travel back to rural Sylhet pretty regularly every kind of year or two. but no obvious other exposure. She wasn't a keen spelunker. You know, she didn't keep bats or anything like that. So we'll come on to things later. So that's interesting. So what we decided to do was exactly as you say. We decided to watch her and wait and see. And I've seen her over the course of the last kind of 9 months, and she remains completely asymptomatic. The other important thing is we have rescanned her, so she has multiple pulmonary nodules. We've biopsied a couple of them and found them to be histoplasma. That doesn't mean that all the nodules are histoplasma and are not cancer. But on repeat scanning, all the nodules have remained exactly the same. None of the nodules have increased in size. And so looking at the treatment, this is a lady who's completely well, has no respiratory symptoms. I was very unkeen to give her a year or two of itraconazole, so we've adopted a watch and wait approach, and she knows to kind of come back to clinic if she develops any respiratory symptoms or any systemic upset. So we haven't treated her.
Can I ask a question?
Yeah.
I might ask the pathologist to say, you know, if as you're biopsying, what does the histology look like in terms of an active infection versus sort of something quiescent, et cetera? Because that might push me toward, maybe there's something smoldering there, maybe her body's keeping it in check because she's competent. But do you want to consider treating to get rid of, or just to reduce the burden of the organisms in the event that maybe she does get immunocompromised for some reason in the future or something happens? So I'd be curious from your vantage, what were you seeing, and would you be pushing, as a pathologist, pushing to treat, or saying, no, I think this is sort of very stable, quiescent, not a lot of inflammatory cells present, etc.?
I should qualify first that I'm a second-year registrar, but beyond that, the level of fibrosis and hyalinization that you see in the centre of that would indicate chronicity and some passage of time. And also the fungal organisms are, and I think in this case, seen quite centrally in the core of that, showing that it's quite walled off and kept separately. I think in more active infections you may get more straying out towards the periphery and within giant cells, and certainly in more disseminated cases you then expect to see macrophages potentially laden with the organism spread surrounding the nodule.
So I think that's helpful.
Yep.
Probably, I'm sure you had that information too. So.
Yes, definitely. And I think that's a good point. We'll come on to a little bit later in terms of what are the risk factors. So you raise a good point. She's clearly got multiple nodules that are stuck that have histoplasma within them. There's no easy test of viability of the organisms within there. So it's feasible that there are still some viable histoplasma organisms in there. So should she become immunocompromised, is there a chance that she will reactivate? But we'll discuss a little bit about what are the risk factors for reactivation and how to mitigate against that. But as things stand, how she is, we think we'll watch and wait.
And the other thing I would say is from the testing, from the serology.
Yes.
If one was, histoserology and testing is a fuzzy science to begin with, as we all know, and we'll probably talk about. But if we were to overinterpret those findings, we don't see mycelium, which was more suggestive of acute. We see yeast, which is suggestive of what's in a body, so you have antibodies reacting to that. We don't see antigen, which is clearly more suggestive of disseminated or acute infection or active infection. So the serology profile also fits with sort of a chronic non-entity.
Something distant. Yeah, Sue.
I suppose for me, working with fungus, I get paranoid about stuff. So seeing budding yeast make me think, oh my God, it's still growing. So for me, it looks like there is potential for infection, and I'd be worried about the person getting flu and getting a chest infection and then something re-emerging. So to me it seems an unusual thing not to treat. Perhaps you could just explain that more to me. I have no idea about the clinical side of this.
So I think I'll come on to some of that when I talk to the pathophysiology. But I guess pulmonary nodules secondary to histoplasma is a well-recognised form of disease where the organism, you're exposed to the organism, and one of the methods of where you can't eradicate it in order to control it is to form a well-formed kind of granuloma around it. So there's this kind of containment aspect to it. And I think it's multifactorial. It's in terms of clinical situation, what the radiology is like, what the serology is like, what the histopathology is like. And I think in this case, she's completely stable, the nodules are stable, she's not immune suppressed, the histopath suggests it's all calm, the serology suggests it's distant. I take your point about the budding, but I wonder whether, I don't honestly know enough about histoplasma to know whether actually you get budding, then the organisms die, and then they're retained in tissue, I think. So that's what I'm thinking.
Is there any evidence on
Well, exactly. So if we decided to treat, what would our endpoint be? Would we just give her a year or 2 years of itraconazole? We're not expecting those nodules to disappear. Those will remain forever. That's an immunological reaction to the yeast that are there. We're not going to re-biopsy her to show that they're gone. So what's our endpoint? And the serology is already bland. So we're not going to treat to negative serology. So I think, again, it's a very good point that we've got no marker to suggest treatment success. So, yeah. Good. So, case number 2. So moving on. So now you know what the theme of the talk is. You can all be brilliant and tell me what the answer is. So, so this is slightly different. This is a 62-year-old man, interestingly also from Sylhet in Bangladesh. But that reflects the population around the Royal London. There's a huge Bengali Bangladeshi population, mainly interestingly from Sylhet rather than Dhaka. So this is a chap in the UK for many years, diagnosed with ulcerative colitis 20 years ago, with multiple biopsies where the diagnosis is not in doubt, but extensive severe disease, has been maintained on various immune suppressive agents. He's declined a colectomy, and because of that, he has annual colonoscopies and biopsies, and he has areas of low-grade dysplasia on his things. He's also got Hep B. He's e-antigen negative and has not yet received treatment. He also has the standard Bengali cardiovascular phenotype of having type 2 diabetes, hypercholesterolemia, and hypertension, but no stroke yet. So he's pretty well, but then presents to ED with quite a short history, 2 weeks, of fever, cough, and weight loss that's recorded as a stone, although that seems a bit excessive, with funny nodular tender lesions on his lower legs that possibly are in the path of his saphenous vein, and a painful scrotum. So this is his history, born in Sylhet, in the UK more than 20 years, and his last travel was more than a year ago. He's quite inflamed when he comes to the ED, so he's slightly anemic. His white cells are okay. He's got a CRP of 160. And those are the skin lesions. I'm not sure they project hugely well, but I think you can see. Yeah, there's redness. It looks like he has had a bypass graft. Maybe he has got more cardiovascular risk than I thought he did. So multiple kind of nodules, a bit of diffuse infiltrate that was quite tender, quite brawny, quite red. And when we first saw this, we had multiple kind of different theories. Could this be a paniculitis? My worry when I first saw him was this is a guy who we know has got colonic dysplasia because of his UC. Has he now got a migratory thrombophlebitis because of malignancy? That was one of the concerns. Is this TB? Is this erythema nodosum because of TB possibly? So he goes on here. He had dermatology come along, Julie, and they do a biopsy, which is cooking. However, during the time that it takes for the sample to cook, he deteriorates over the course of the next little while, and multiple things kind of come along. So his scrotum gets worse, he gets epididymal orchitis, there's no sampling taken, no biopsies done. He then develops frank hematuria. We were worried because there was a lot of urinary jiggery-pokery that he then ends up getting Fournier's gangrene with a lot of scrotal swelling, which it wasn't. He then gets new skin lesions on his abdominal wall. He becomes hypotensive, oliguric, confused, develops DIC, and develops a blood picture that we think looks a little bit like hemophagocytic syndrome. So he becomes pancytopenic, his ferritin starts taking off, his triglycerides start taking off. So he's whisked off to the ITU where he's intubated, his cardiovascular system is supported, his renal system is supported, and because of the pancytopenia, he has a bone marrow performed. So I think the other thing to say is that in this story, as part of his workup, especially with his UC and his immune suppression, he's found also to have a CMV viremia, and there's a concern that this might be kind of causing some of the skin lesions and the pancytopenia. So he's treated for CMV with ganciclovir. Towards the end of about the third week of his stay, the biopsies come back. So I'll ask Vivek to come back up and talk us through these are the skin biopsies.
So yeah, we've got a section of skin here. The epidermis looks a bit atrophic. There's not many of the rete pegs which are normally present here. It's quite even. There's not particularly much hyperkeratosis on the surface, but the most kind of striking feature are these aggregates of inflammatory cells which are scattered at all levels through the dermis, and actually you can see them extending down into the subcutis here as well. So on much higher power, looking at one of these aggregates, we can see that this is actually a loosely formed granuloma. So we haven't got the kind of peripheral palisading typically seen in tuberculoid granulomas. We can also see necrosis present here with nuclear debris kind of scattered throughout. There's no suppuration particularly present. There's a few lymphocytes and plasma cells scattered around, but these are mainly epithelioid histiocytes and macrophages. And we can see here and a few other scattered areas the typical appearances of histoplasma capsulatum.
I think there's...
Is it one more? Oh yeah, sorry, grey cop as well. So yeah, and this is the same granuloma actually photographed at higher power. And again, you can see the nice illustration of the narrow-necked budding here and uniform 2 to 4 micrometer size of these things. So it's about half a red blood cell in size.
Thank you. So we go. And just to knock through the rest of the case, so as you might, so what's interesting is we then looked for histoplasma using our kind of standard array of tests. So interestingly, the histoplasma serology was completely negative. So yeast antigen, mycelial antigen, immunodiffusion negative. 16S of the skin biopsy was positive. The skin biopsy actually grew histoplasma capsulatum, and on the bone marrow, they saw hemophagocytic syndrome. They saw hemophagocytosis. And the culture of the bone marrow also grew histoplasma capsulatum. No, I think we sent the skin biopsy because we were worried about histoplasma. We sent it all to Liz. It was. Sorry, Holly. Sorry. Credit where credit's due. Holly did the 18S. Very good. So we 18S the skin and got it there. Fine. And as we'll come on to a little bit later in terms of the lab infection control aspects. But as soon as you start finding histoplasma in the lab, everyone gets a bit nervous. Cat-free organism and sending it off and things. So histoplasma, it's not in doubt. And this is just a note of the clinical course. So this is when he kind of comes in. We see him around kind of day 8 of his admission, noticing the skin rash, suggesting he gets a kind of a biopsy. He then deteriorates, goes to ITU, has a rectal biopsy showing CMV colitis, has the usual kind of escalating empiricism going through various antibiotics and antifungals. We find CMV, he's given ganciclovir and then foscarnet because he's getting worse. And only then, when we get the histoplasma back, do we start ambisome, but by that point it's a little bit too little, too late, and he dies.
Why did it take so long to get the skin biopsy result back?
So I've massaged the story slightly in that the skin biopsy was probably done a little bit later in his stay. So his skin biopsy was probably done around here. So he came in with UC. We got very fixated about the possibility of cancer and about CMV. And then only around here did we kind of think, well, hang on a minute, those skin lesions look a bit funny. They're not going away. What could they be? So yes. Yeah. Almost. I think so. And we'll come on to why that might be the case later, exactly. So.
Do you think if you obviously this is a challenging case because you're not thinking clearly this is the kind of case where an antigen test is very, very helpful. I bet a urinary antigen would be positive. Yeah. Because antibodies are just, again, this is the fuzzy part of antibody testing. But do you think you would have ordered it if you had it available?
Yes.
And at what point would you have ordered it, I guess? Because you might not have ordered it early enough, or maybe you would have. Yeah, no, exactly. Because I saw him when he was here before he went to ITU, and then different colleagues took over on ITU. But it was just whether at this point should we have thought, what is it? Should we have done it here? Had we done it here, then the outcome may have been very different. Exactly.
Did you do collect manner at any point?
Did we do a collect manner? I don't know. Is the honest answer? Not by the time I left him going to ITU. I don't think we did actually going through.
John,
No, he wasn't. He was only on. Well, not only on. Was he on? No, he wasn't. He was on a mixture of antimetabolites and steroids. It had been for a while. Yeah, so he's clearly. But I guess that begs the question: is he got CMV because he's got marrow involvement with his histoplasma? I guess which, or has he got critical illness and the CMV is reactivated? But so that's case 2. Case 3 is another interesting case that you know the answer to, but with a slightly happier ending. I'll précis it with that, but no less dramatic, I think. And this is another. I think the thing about this case is thinking about histoplasmosis as a mimic of things. So this is a 63-year-old man. No points for guessing where he's from. He's from Sylhet in Bangladesh. And he has a background of hypertension and reflux. And he presents to A&E with a 2 to 3 week history of red tender nodules on his shins, systemic upset, fevers, night sweats, weight loss, malaise. Again, he's got a mild neutrophilia, a bit of a lymphocytosis, and he's a bit inflamed. So he goes on to have imaging, and the imaging shows relatively diffuse lymphadenopathy, so supragravicular, mediastinal, axillary. He's also got an adrenal lesion. Histology and microbiology, we get an FNA of a cervical node, and it shows some granulomatous inflammation with a combination of necrotizing and non-necrotizing. It comes to us, we do our usual workup, routine cultures are negative, mycobacterial cultures are negative. Now, you know the answer to this case, but put yourself in our shoes. This is a man from Bangladesh who has got widespread lymphadenopathy with necrotizing granulomas. What is the diagnosis? TB. This is TB until proven otherwise. So, just to show the histology, this is the lymph node histology.
Yeah, so again, there's complete replacement of lymphoid tissue here, and a mixture of fibrosis, amongst which are scattered loose epithelial histiocytes, a few lymphocytes in between, with some necrosis in the centre and a couple of giant cells present here, but no organisms visualised. Next.
And this got a ZN stain, a Grocott, and I think possibly a Wade fight. No organisms seen on any of that. So he started TB treatment, but with credit to the TB team who saw him, they saw him at 2 months, at about the time we would step down from standard quadruple therapy to dual therapy, but he still wasn't right. He was still having sweats, he was still losing weight, his exercise tolerance was going down, and so they quite rightly went, this isn't right, you need to come into hospital, we need to do more tests. And they did. He'd become markedly anemic. He dropped several grams worth of hemoglobin. He'd had what we thought was an initial reactive thrombocytosis, which had dropped to a marked thrombocytopenia. He dropped his albumin by quite a bit, normal using his LFTs, but a borderline ferritin. So he was quite inflamed. He had quite profound acute phase response. Interestingly, his repeat imaging showed his lymphadenopathy had resolved, and the adrenal lesion he had got better. So that on the one hand, you've got lesions you're treating as TB, they're a bit better, he's not better, and now he has a new lytic lesion in his right iliac crest. So everyone goes, okay, fine, he's got cancer. Let's go and look for the cancer. So this is just the slides. This is his presentation CT. So that's an adrenal gland apparently, and that's quite a big adrenal gland apparently. And you follow it several months later, and that's the adrenal gland, and that's pretty much back to normal apparently. So it's got better on TB treatment. He's not had any steroids as part of his TB treatment. He's just had standard TB treatment, and that's got better. What's changed, though, is that's his original CT of his iliac crest. That's his iliac crest now. That's looking a bit more moth-eaten, and the integrity of the cortex has gone. So he then goes on to have a biopsy of his iliac crest. Back to Vivek to tell us more about it.
And yeah, it looks quite similar to the lymph node, really, doesn't it? Again, very pink, slipper-shaped nuclei of epithelioid histiocytes, giving them away, and quite an obvious poorly formed granuloma with the necrotic centre in the middle, nuclear debris. It's a bit of an eye of faith thing here, but possibly some of these foci with the little halo around may represent some organisms.
I guess just comparing that to the granuloma that we saw in the first case, where it was a huge ball of necrosis and well-formed things around a tiny speck of infection in the middle. This is much more, in my mind, a much more loose, much less coalesced. So in terms of Tom's question, in terms of does this look quiescent or active, in my head this looks active. This is the body trying to control something but not doing a great job. Oops.
Yeah, and again, more kind of obviously demonstrated due to how loose this is that these are sort of sitting within macrophages, but again, same yeast.
There you go.
Can I ask you,
all such tissue samples, or is it just based on the previous slide that you would do a growth for?
No, I mean, wherever we see granulomatous inflammation, it's, even when there's obvious other explanations for it, it's pretty much routine across the board.
Super. So there we go. So this is following up. This is an active current case. So we sent the urinary histoplasma antigen off to Indianapolis, and it was positive. So we got positive urinary antigen. His histoplasma serology is still cooking. But this is a guy normally fit and well. No obvious immunological reason why he should get disseminated histoplasma. So we're doing an immune workup. We've deferred doing it when he was critically unwell because immunology tests are often quite difficult to interpret in the setting of an acute phase response. What we've got back so far is he has an elevated polyclonal IgG, which is likely reactive to the chronic infection he's got. He's HIV negative. He's now a good deal better, so his lymphocyte subsets are cooking. We're just wondering about things like idiopathic CD4 lymphopenia and things. So that's his past history. We did get a bit excited about his trip to Milan because there is some autogenous histoplasma within Italy. He was treated with, and is still on liposomal amphotericin. He's approaching the end of kind of 6 weeks, and he's got much better, so he's almost ready for discharge. So his albumin is back to 30, his platelets have come back up, his hemoglobin's come back up. So a slightly, better outcome than the last case. So.
How did it take to get the results back from Indianapolis?
So it took about 2 weeks. Yeah. So we treated on the basis of the histopath. So that result was received. He started on amphotericin. Samples went, but we only sent urine, so we couldn't ask Indianapolis to add on a serology. So that's gone to Bristol as a bit of an afterthought. So yeah.
And did the histology get down to Royal London, or did it go to St. Thomas's?
No, Royal London.
Did you carry on treating the GP?
Yes. so someone from Newham who knows the case. Yes, very good. Fantastic. Cool. So those are the 3 cases. They're all about histoplasma. And just in my head, going through the 3 cases, there were 3 things that really leapt out to me. One was about epidemiology. The 2 was about pathophysiology and the spectrum of disease. And then 3 was about the challenges around diagnosis. This is all about kind of challenging cases. So the issue is the epidemiology, referring to the talk, and where did that come from? So why these 3 people, all from Celette? We have a 4th case with nodular disease, which I haven't shown for the interest of time, but 4 cases all from the same place, all with histoplasma. Just a show of hands, who knew histoplasma was in Bangladesh? I didn't. Tom did. It's fine. Yeah. I mean, there's a we'll come to that in a minute. But then the interesting thing also is about the capacity for it to reactivate and its latency, and then the diagnosis. So I'll fly through these. So this in my head was the epidemiology of histoplasmosis. So it's the Mississippi and the Ohio River basins, but and that was essentially it, with a few scattered cases in maybe Central South America. That was my understanding. But I guess the real thing to think about is how has that knowledge been derived? How do we know? Why do we know that it exists in those areas? It's because of seroprevalence or prevalence surveys. The real challenge with that is, as we'll come on to, serology will become negative after 3 or 4 years. So if you go out to a population and do blanket histoplasma serology, even in an endemic area, you will only find about 5% of the population with positive serology at the time, even in an area that you know it's endemic. It's not a reportable disease in most places, so trying to get accurate data about numbers of cases is very difficult. You can look in the environment, but that's quite laborious and not routinely done. And so our knowledge of the prevalence of histoplasma is based on a histoplasmin skin test. And most of those tests were done in the 60s and 70s with limited global coverage because people didn't go out globally to do the histoplasmin skin test. And now it's no longer done because there's no commercial source of the histoplasmin reagent. So just a bit about the test. It's like a MON2. So you inject the histoplasmin antigen into the dermis, you wait for 48 hours, and you read the size. So this is, I don't know if it projects particularly well, but if you see down here, it says diagnostic skin tests, tuberculin, histoplasmin, blastomycosis. So you use the same ruler to measure the same sort of delayed hypersensitivity. You just measure it with the same ruler, but it depends on what antigen you stick in the skin. So I guess it's to kind of show that our knowledge of the epidemiology of histoplasma is old and wrong. And actually, when you start looking and people start collecting cases the geography changes. So the blue, well, the slightly purplish bits are areas where people have found cases of histoplasma. And this is just in cases of histoplasma capsulatum in individuals with HIV. The circles are the numbers of published cases in the literature of only AIDS-associated cases, not all cases. So you can see the geography moves from that spot there to what you could draw a line between the Tropic of Cancer and the Tropic of Capricorn, and you'd have a band across the world, I think. It would be a fairly reliable thing to say. People have gone looking specifically, so you know, when you look along the Yangtze River, the histoplasma skin reactivity ranges between 6 to 50%. People have looked in Thailand, in India, in Australia, and again, the more you look, the more you find in those sorts of areas. So it's more common than perhaps we think. And if you think about Bangladesh specifically, this is just a blown up picture from the map. Bangladesh sits in there. I'm not sure whether, I mean, it's not coloured in, it's there. So, but actually if you do a PubMed search for histoplasma in Bangladesh, you'll get 6 hits. And there's a nice review from earlier end of last year from, including David Denning, when you're looking at it, they did a literature review and reported 16 proven and 21 possible cases, all HIV associated. So we've now got 4 cases, all from Bangladesh, all non-HIV related. So I'm sure there's much more of it out there than we perhaps think there is. So that's a bit about the background to it. And then talk about a bit about mycology. I think this is brilliant in terms of, you know, it's a bit of a shapeshifter. So in the environment, it's a mold form. In the human body at 37 degrees, it turns into a yeast form. And this is the transmission. So in the environment, when it's in its mold form, in order for sporulation to occur, it needs humidity, it needs a bit of warmth, and it often needs acidic, nitrogen-rich soil. And the significance of that is that it's often soil that's enriched with bat droppings or kind of bird droppings and things, and that has relevance to how you think people kind of acquire it. So most of the risks are people who've been kind of fertiling in caves where there have been bats and bat droppings on the floor, you know, derelict outhouses where there have been kind of crows kind of roosting, you know, messing around with chickens, or kind of demolition work where there's a lot of aerosolization of you know, dust and the spores in the environment. So those are the different. You know, I was aware of the caving, so you can ask, have you been caving, but not. I wouldn't have asked about these things, you know, before looking into these cases. The Pathophysiology, I think, is really important because it explains the spectrum of disease, and this is just a macrophage stuffed full of histoplasma. This is a very nice picture from the CDC website. But just look at the similarities, I think, between histoplasma and TB, I think, is a really important way of conceiving how histoplasma causes disease and the spectrum of disease it may cause. So you kind of inhale your histoplasma from the environment into your respiratory tree. It's engulfed by your alveolar macrophages. But then the challenge is again, this is a slide borrowed from a nice review of non-tuberculous mycobacteria and TB. The same slide applies to histoplasma. So your pulmonary macrophage engulfs your organisms, but can't kill them. So for some reason, you know, the way that TB evades killing with the macrophages is partly understood. I think in histoplasma it's less well understood, but you end up having viable histoplasma within your macrophages. They then recognize as viable organisms and talk to your T cells over here via signaling via IL-12. Your T cells then kind of go, yes, you've got, you know, viable organisms, we need to try and kill them. And they end up signaling back to the macrophages using interferon gamma to try and induce intracellular killing within the macrophages. So by, you know, increasing phage lysosome fusion, increasing production of antimicrobial peptides and so on. So that's the response that interferon gamma induces. And then you have that's to try and kill the organism. If you then can't kill the organism, you then control it by making a granuloma. And we know from TB work that in order to form those well-formed granulomas to contain your infection, you need TNF-alpha. And this comes in with relevance, especially these two cytokines, when you look at risks for disseminated or invasive mycobacterial disease. And the same is true for histoplasma. So where things can go wrong, you can give people anti-TNF agents. You can have defects in your interferon gamma signaling in bits and pieces. You can have problems with, this is rarer, but in terms of IL-12 signaling. And the same things that make you at risk of disseminated TB or reactivating your latent TB are the same risk factors for histoplasma as well. And this is just a range of presentations. This is something I pinched from Up to Date and a picture from Joe Wheat. It's important to say that the majority of cases are completely asymptomatic. So you have your original exposure. The body is very well equipped to eradicate or contain the originating infection. You can then get pulmonary infection, be it acute or chronic, and then you can get kind of disseminated infection. I mean, I think, again, that fits very nicely with the TB paradigm in terms of, focal TB, disseminated TB, but also you've got your capacity for latency as well as important. You've got your organisms residing within your macrophages and your granulomas. If you reduce the integrity of those with anti-TNF therapy, for example, then you've got the risk of secondary dissemination. In the interest of time, what I'll do is I'll just flick through these quite quickly. So various presentations of acute pulmonary from very much lots of lymphadenopathy, possibly driven more by a robust immune response compared to miliary acute pulmonary disease, again mirroring mycobacterial disease. And then you can get kind of chronic cavitatory pulmonary histoplasmosis. Again, that's indistinguishable in my mind from a TB lung. It looks very similar. And then you get your dissemination. So you've got your fantastic histoplasma-laden macrophages that will migrate from the lung into your reticular endothelial system, so into your lymph nodes, into your bone marrow, and I think and into other lymphoid tissues. And I think that explains the pattern of dissemination. So that's another picture. That's just a bone marrow chock full of histoplasma. And so what are the key risk factors for disseminated disease? So it's impaired interferon gamma signaling, so some of the innate defects in interferon gamma, impaired TNF signaling, and some of that is innate signaling, so extremes of age, so very young children, pregnancy, older individuals, and it generally follows where your macrophages go. So you'll get involvement of the reticular endothelial system, so you'll get lymphadenopathy, hepatosplenomegaly, involvement of the marrow leading to cytopenias. But then if you get an over-exuberant immune response to try and counteract it, that's when you may push yourself into the hemophagocytic syndrome aspect as well. And then just flying through kind of diagnosis, you've got histopath, culture, serology and antigen testing. So these are the diagnostic criteria. I'll skip through those. The real challenge is that it's not notifiable, and in the states where 10 states do notify, but they use differing definitions. There's been a recent bid by the Council of State and Territorial Epidemiologists to try and define, confirmed cases and probable cases. This is quite a useful slide, I think, from a nice review in Jekyll and Micro from last year, and it just shows the various sensitivities of different testing strategies depending on where you are in your disease process, whether you've got acute pulmonary disease, subacute pulmonary, chronic pulmonary, and then disseminated disease. And you can see that your culture rates, your histopath will change, your antigen detection rates will change, your serology will change. The caveat to the serology is that if you're immunosuppressed, then your serology can clearly be falsely negative. Well, it can be negative even in the presence of infection. So I guess histopath, Vivek's kind of talked about. I guess one of the things that Vivek was going to talk about as well is some of the differentials that of the findings that we can see from there.
So Histoplasma capsulatum is classified amongst the small yeast, and included amongst that would be Penicillium and Candida glabrata. Candida glabrata we've already seen today. It shows a little bit more variation in size, and is usually extracellular. The inflammatory pattern's different, tends to induce more of a suppurative response. Histoplasmosis is more of a granulomatous response. The other thing is also the staining characteristics are a little bit different, and it's much more basophilic on an H&E, Candida glabrata. It almost looks like it's been PAS stained on the H&E, whereas from the histoplasma you saw earlier, it's more pink and eosinophilic. And histoplasma, of course, has that halo around it, which is not always seen, but is useful, which is retraction artifact and leads to the false name of capsulatum. Cryptococcus is much bigger, but it shows variation through all the ranges of size from around 5 to 20 micrometers, and has quite prominent capsule that you can see almost a refractile nature, usually on the H&E, and that stains positively with mucicamine. Where it can be difficult is if you've got microforms of Cryptococcus, and also what have been called the capsule deficient, or what should probably be called porcicapsular examples. They could prove more of a problem, but again, a melanin stain can be quite useful here. So Fontana Masson will stain them black as well. Blastomycosis is in a different size category, which would be in medium size, so it's 8 to 15 micrometers in size, and it's got broad-based budding. Cryptococcus, I should say, also has narrow-based budding, but if you assess it on the mucicamine stain, it can look broad budding. Pneumocystis is a little bit bigger and doesn't bud, mainly extracellular, and again, if you're lucky on the GROCOT, you'll see the intracystic focus, which looks like a little pair of brackets inside. Penicillium separates by cross-wall septa, so they look a bit like a pill or a capsule, but are similar otherwise in size. And protozoa are also similar sizes. Leishmaniasis is one of the ones where we're constantly questioning, is it histoplasm or leishmaniasis? They wouldn't stain with the GMS, and they do look a bit different. They don't have the halo, and you've got, you should be able to see, although it's difficult, the kinetoplast and the nucleus. And obviously, Chagas and Toxo can affect somatic cells as well, which histoplasma wouldn't. I suppose the only other one I would have said was, it's the wrong demographic here, but coccidioides, if you've got ruptured spherules and can't see the spherules, the endospores can look quite similar.
Thanks very much. Right, I'll fly through the rest. So, and then another key part of the diagnostic pathway is your urinary antigen testing. Now, up until recently, our only option for urinary antigen testing, or antigen testing per se, has been to send samples to Mira Vista laboratories in Indianapolis in the States. And so when these cases first came up, talking to our lab manager in terms of the logistics of sending a sample to there was a lot of wailing and gnashing of teeth and pulling of hair, because it's really quite difficult, because you've got to fill in countless forms, because it's got to get through US customs, you've got to pay for shipping, you've got to pay for the test. So we worked out that, not including lab time, sending a test to the Mira Vista guys costs us about £200 or so, and the turnaround time, as we said, is a couple of weeks. There are other tests available. One of which that's FDA approved is an EIA now, and it's third generation manufactured by IMI. And there are two folk from IMI in the audience who you can talk to kind of afterwards. I'm not sponsored by them, but it's just the logistics are easier. It's an EIA. You can buy the kit. You can run the kit in your own lab. Both of them do the same sort of thing. They're both quantitative, so your antigen titers are useful in terms of monitoring disease response and trying to predict recrudescence. Again, combining urine and serum increases sensitivity. They'll have the same kind of range of false positives, but the logistics for the IMI side seems, intuitively kind of easier, and keeping my lab managers on side is always, an important part of my job. And then the last thing to talk about, just to fly through, is serology. Currently, it's a combination of complement fixation on the left here, and immunodiffusion, and it's tricky in that different bits will appear at different times and last for different lengths of time. So, I guess the take-home message is it's a bit tricky, it's a bit laborious, and I guess the important thing is that it can be negative in two settings. One, if you had the infection a long time ago, which is why it's useless for serosurveys. But also, if you're markedly immune suppressed, it may also be negative as well. So, diagnosing histoplasma, there is no one test that will tell you everything. So you do need multiple tests if you're pursuing that as a diagnosis. There's a lot of debate about who should you screen. So this is a bottle of infliximab, HIV. That's a kidney transplant. That's a bone marrow transplant. We've already talked about the risks being immune suppression, anti-TNF treatment, interferon gamma impairment, that sort of stuff. What are the risks of reactivating latent disease? There have been various kind of studies. Interestingly, in the solid and bone marrow transplant, even in endemic areas, the risks seem pretty low. So kind of less than 1% of people living in endemic areas will develop reactivation of their latent disease. In HIV, it's a different story. So if your CD4 count is less than 50, your hazard ratio for developing invasive infection is 47, compared to if your CD4 count is over 500, so clearly an important risk. One of the biggest risks does seem to be the anti-TNF agent, so infliximab. So the risk is, the quoted thing is 20 per 100,000 patients, and if you compare that to a TB risk of 54 per 100,000 patients, it's not far off. It's the same order of magnitude, but we have a protocol for screening patients who are from endemic areas for latent TB if we're giving them anti-TNF. We don't for histoplasma. And a question for the audience is whether we should. But then the question is, how do we screen? We already know that serology doesn't work because it'll be negative. So the question then is perhaps more about vigilance during their treatment and a lower threshold for urine antigen testing, which may be easier now that we have a test that's more readily available. And so this is just a useful, interesting list of references. That's a global epi. Diagnostics, that's a nice review. Some useful kind of data in terms of immunosuppressed patients, IDSA, and a nice review from a little while ago now, but CMR. And that's really it. So thank you very much for your attention. Let's have some questions.